Today we will start with our first session of the chapter of neuroradiology with a few presentations. The first is Introduction to Neuroimaging. It was prepared by Dr. Marwa. However, due to some special circumstances, she could not come to the hospital today, so I will present it on her behalf. So if I sound a little bit not very well prepared, excuse me, because I read it last night. Okay, so first of all, we have to know the ventricular anatomy of the brain. The ventricles, as I'm sure all of you know, composed of the lateral ventricle, the third ventricle, and the fourth ventricle, and they are connected by special foramina. The lateral ventricle is connected to the fourth ventricle by the foramen of Monro, and the third ventricle is connected to the fourth ventricle via the cerebral aqueduct of Sylvius, and from there the CSF will flow into the spinal canal via three foramina, one in the midline called the foramen of Magendie, and two on each side on the lateral aspects called the foramina of Luschka. Okay, the CSF being produced in the lateral ventricle by the choroid plexus, which are the location of the choroid plexuses. You have one in the atrium of the lateral ventricle, and in the temporal horn of the lateral ventricle, and in the third ventricle, and another one in the fourth ventricle. So these are the main sites of production of the CSF. First, let's talk about cerebral edema. Cerebral edema, there are three types of cerebral edema, which are the cytotoxic edema, the vasogenic edema, and the interstitial edema. Each one has a special indication, special cause, specific causation, So first of all, the cytotoxic edema occurs when there is cell death. When there is cell death, there is cytotoxic edema. The thing about it is that it involves both gray and white matter. If it involves gray and white matter, it is cytotoxic edema. It means there are dead cells. Okay. What will happen is that the sodium potassium pump will start to fail, and the water will flow from intracellular to the extracellular compartments. And this will result in the edema. And as the cytotoxic edema, or edema in general, but best detected by the diffusion weighted imaging and the ADC, the apparent diffusion coefficient map. It will be positive within as little as 20 minutes after the onset of stroke. When we say cell death in the brain, we are talking about stroke. Okay, 20 minutes after the onset of stroke, diffusion becomes positive, and will stay that way for about 2 weeks till we go to change it to subacute phase. After 2 weeks, then the ADC, which is low in the acute state, gets higher, and then becomes imbalance, and the edema or the diffusion restriction will disappear. Regarding the vasogenic edema is due to increased capillary permeability. So whenever there is anything that causes the capillaries to leak, there will be vasogenic edema. Vasogenic edema involves only white matter. It does not involve gray matter. So typically you see these finger-like projections into the subcortical regions, while the gray matter is relatively intact. This happens when there is an infection, neoplasm, abscess, some types of infarcts, not all of them. Okay, while interstitial edema is due to increased CSF pressure. When the CSF pressure in the ventricles is higher than usual, it will start flowing through the ependyma into the brain, resulting in these hyperintense areas in the ependymal layer of the ventricle. This is called increased transependymal flow. What does that mean? It means there is active hydrocephalus. There is hydrocephalus with high pressure. Active hydrocephalus. Okay. Brain herniation is an entity that all of us should know and know what are the risks of the herniation. As we know, the brain is surrounded by dura, and the dura is hard. Hard, why? Because it keeps it in place. So if there is, since the intracranial compartment is limited, it's bone all over, it's fixed volume, okay? When there is increase in the size of the brain at one part, the brain will herniate to the opposite part, okay? And this is risky, and it's not good at all, because it can lead to brain damage or sometimes even death. There are different types of herniations, including the subfalcine herniation, when the brain goes under the falx cerebri into the other side. There is uncal herniation, there is central herniation, okay, and there are different types of complications with each kind of herniation. For example, in the subfalcine herniation, it will cause compression of the anterior cerebral artery, okay, because it will be compressed against the falx here. If there is downward or uncal or transtentorial herniation, it will cause ipsilateral third cranial nerve paresis, compression of the PCA, Durette hemorrhages, we will talk about that later, and compression of contralateral cerebral peduncle. While cerebellar or tonsillar herniation, this occurs when you do lumbar puncture with high intracranial pressure. The brain will herniate through the foramen magnum, and this is cause compression of the medulla oblongata, which may be fatal. You can kill a patient if you do lumbar puncture on a patient with high intracranial pressure, okay? For example, let's see the subfalcine. I think the most famous one is the subfalcine herniation. We call it midline shift. Okay, this is very, we see it a lot. When there is a mass or tumor or pathology here, there is edema, the cerebral hemisphere gets swollen and it herniates to the opposite side under the falx. This is the falx, it's herniated to the opposite side. While transtentorial or uncal herniation, the uncus will herniate through the tentorium cerebelli, causing compression on the brainstem and the cerebral peduncle. Okay, like in this case. This is the pathology, the tumoral. There is something called ascending transtentorial herniation. When the pathology is in the posterior fossa, the disease is below the tentorium. So instead of herniating downward, it will herniate upward. Okay, and this will cause compression of the fourth ventricle and the aqueduct of Sylvius, and it will cause hydrocephalus. Okay. Cerebellar tonsillar herniation, as we said, we talked about, it will herniate through the foramen magnum into the upper part of the spinal canal, causing compression of the medulla oblongata, which is very, very dangerous. Okay, so normally you'd see the cerebellar tonsil only 2 or 3 millimeter inferior to the foramen magnum. More than 5, there is something wrong. Can be congenital, can be acquired. Congenital in cases of Chiari malformation, acquired cases of herniation, tonsillar herniation. Hydrocephalus is increased accumulation of CSF in the CSF spaces in general. There are different types of hydrocephalus. It's either communicating or non-communicating. Non-communicating, where there is something obstructing the flow of the CSF, like a tumor, like a whatever, mass, fracture, infection, anything that obstructs the flow. It will cause dilatation of the CSF spaces above the level of obstruction. While communicating, there is nothing obstructing the CSF flow, but there is something obstructing the CSF resorption. So everything is dilated. Where does the CSF get resorbed? أحد يعرف؟ وين الابزوربشن مال الCSF وين يصير؟ لا مو السيستر، بالارachnoid granulations. Arachnoid granulations. Okay? And there is something called normal pressure hydrocephalus. It's hydrocephalus with everything is normal, but there is hydrocephalus. Okay, usually in older age group called Hakim-Adam syndrome. Now let's talk about differentiation of the the intracranial compartments. There every lesion, any pathology that you see, you should classify either intraaxial or extraaxial. The first word in your report is there is intraaxial lesion, there is extraaxial lesion. This word intra or extraaxial change the whole differential diagnosis. Okay, so clues to the extraaxial: when the lesion is external to the pile membranes, the meninges and subarachnoid space, all of them are called extraaxial. Anything within the brain tissue, it's intraaxial. Okay, how do we know this is extra or intraaxial? There are some signs. First, displacement of the pile vessels. You can see the vessels displaced. This indicates extraaxial. If the gray matter is buckled over the lesion, this indicates extraaxial. Widening of the adjacent CSF spaces here and here indicates extraaxial. Changes within the adjacent bone, like hyperostosis in case of meningioma, for example, indicates extraaxial. These signs we should look for. To sometimes it's not that easy to say this lesion is intra or extraaxial. The basal cisterns are CSF spaces that surrounds the base of the brain, base of skull. Okay, around the midbrain and the brainstem, there are multiple collections of CSF we call cisterns. There are the quadrigeminal cistern, the ambient cistern, the interpeduncular cistern, the prepontine cistern, supracellular cisterns. These are CSF spaces. We should know them because they are involved in a lot of different kinds of diseases and pathologies, and they might be obliterated or dilated or whatever according to the disease. Of course, MRI has revolutionized the neuroimaging. Everything related to brain now is go to MRI. Because we'll have a little bit talk about the use of MRI in the neuroimaging. First of all, the main features of the MRI is the T1 relaxation time and the T2 relaxation time. T1 relaxation time is when the protons goes back into the longitudinal axis. It relaxes and goes back into the original magnetic field, and when you take a T1 weighted image, you will have a hyper intense signal that produced by the protons that relaxed the fastest. Like for example, fat protons in the fat will appear hyper intense because they relax the fastest. Okay, well, if you take a T2 weighted image, you will have hyper intensities caused by the protons that stayed or relaxed the slowest, let's say, stayed in the transverse axis. Okay, like for example, fluid. The main sequences that we take by MRI for the brain are the conventional spin echo T1, conventional spin echo T2, and the flare and diffusion and ADC and things like that. We'll talk a little bit about them. T1, we have a short TR, which is time of repetition, and TE, which is time to echo. TR, time repetition, with time echo. Both of them are short. The TR is around 300 to 600 milliseconds, while TE is about 10 to 30 milliseconds. Why do we use T1? For anatomy. It's excellent for demonstrating anatomy, not very good in pathology. The things that you must memorize, and they are very common exam questions, are what are the causes of T1 shortening? When we say T1 shortening, means hyperintense on T1. What are the things that are white or hyperintense on T1? These are gadolinium, fat, proteinaceous substances, methemoglobin, melanin, mineralization like copper, iron or manganese, slowly flowing blood, and calcium rarely. Might happen, but rarely. Okay? For example, here you can see this is an enhanced meningioma. Contrast appears hyperintense on T1. The TE is the opposite, not the opposite, it's a different kind compared to the T1. It has a long TR, about 2000 millisecond, and a long TE, about 70 up to 100 millisecond. Why do we use T2? For pathology. It's very good in demonstrating pathology. What are the things that appear hyperintense on T2 weighted images? They are the paramagnetic stage of blood, calcifications, fibrous lesions can appear hyperintense on T2, highly cellular tumors with high nucleus to cytoplasm ratio, vascular flow void, and mucin. Sorry, these are causes, I'm so sorry, hypointense on T2, things that appear dark on T2, not bright, dark on T2, okay? They are the paramagnetic stages of blood like hemosiderin, old blood, calcifications, of course it appears hypointense on T2, fibrous lesions, highly cellular tumors like for example lymphoma, they have a large nucleus, small cytoplasm, so a little bit of water, not much water, small amount of water, so appear hypointense, flow voids, vascular flow voids, of course they appear hypointense, and mucin. Fluid attenuation inversion recovery, or what we call it FLAIR, fluid attenuation inversion recovery, it's a T2 minus the CSF. T2 image minus the CSF. So for the first look, you think it's like T1. It looks like T1 because the CSF is dark, but it's not. Why? Because white matter is darker than gray matter, while on T1 white matter is brighter than gray matter. بالفلير اللي هو T2 white matter dark, gray matter bright. T1 white matter bright, gray matter dark. Flare is a T2, so it goes with the T2. The white matter will be dark and the gray matter will be bright. Okay, so if you look carefully, you know this is flare, not T1. Okay, for example, this is a T2, conventional T2 weighted image, and this is a flare. Okay, you can see the gray matter is bright and the white matter is dark. Okay, and exactly the same here. The gray matter is bright, the white matter is dark. When you suppress the CSF, only the fluid that is not CSF will remain. For example, increased transepidermal flow will be demonstrated very nicely. Okay, or any gliosis or lesion, whatever. And it will show pathology even better than T2. There is something called T1 flare. Someone might ask, T1, the fluid is dark. Why do I do flare? The idea of flare is to make the CSF hypo. There is a sequence when the signal, any kind of signal from the CSF is removed, even on T1. And this will provide superior delineation of contrast enhancement. The contrast enhancement on T1 will be even better than on T1 conventional image. If you use T1 flare. We don't use it here a lot, by the way. So you can see here there is the T1 flare versus T1 contrast. You can see here the enhancement is better, perfectly demonstrated. Okay, this is also again without contrast. You can see the T1 flare versus T1. T1 flare is even higher anatomical details. How you? It's like T1. Yeah, it is T1. It is T1. No, that's flare and it's not flare. You look at the TR and the TE. You see the TR and the TE? It's even higher. Now, there is something called proton density. Proton density is something in between T1 and T2. It's in the middle. It has different criteria. There is long TR, short TE. Not short or long. There is long, short. Okay, and this is used especially for evaluation of MS, multiple sclerosis plaques. It's demonstrated even better than T2. For example, you can see here on this T2 image there is nothing or not very obvious plaque. On the proton density, you can see the lesion is much better demonstrated. For me, myself, I don't like proton density. I think it's confusing. Anyway, regarding diffusion restriction and ADC, when diffusion measures the restriction in the movement of the water molecules, normally they are not restricted. When the water gets out of the cell into the extracellular compartment, it becomes crowded. They cannot move. They are restricted. Diffusion will measure that. With every diffusion, we need to measure ADC, apparent diffusion coefficient. Why? Because some artifacts might appear as diffusion restricted, and diffusion restriction will appear hypointense on ADC map. If they are hyperintense on ADC map, it's called T2 shine through. This is an artifact. It's not a real diffusion restriction. Okay? Also, viscous fluid like abscess can have diffusion restriction because it's viscous. They cannot move the cells. Okay? For example, you can see here, this is an diffusion weighted image. You can see the diffusion restriction. How to confirm it is not an artifact? See the ADC map, the apparent diffusion coefficient map, and you can see it's hypo. When it's hypo, this is a real diffusion restriction. Okay? A lot of different other examples of the diffusion restriction. I will not talk about them due to time purposes. When we do a diffusion, there is something called the B-value. Okay? This part I want you to understand. B-value, it's the sensitivity for detecting diffusion abnormalities. Okay? The higher the B-value, the more contrast the image. It will be more sensitive. So why we don't do the highest B-value possible? Easy. Because it will cause decrease in the signal to noise ratio. يعني higher B-value, less signal, more noise, less clear image. كل ما يزيد البي value كل ما الإيمج clarity تقل. How to overcome that? If you need a higher B value, you need to increase the time of imaging. يصير أطول التايم حتى ليش؟ To make the signal more and decrease the noise. Okay? Usually we use B value of around 1000. Okay? Sometimes some machines have 500, 1000, 2000. Standardized 1000, but you can do more, but you will lose quality. You will lose details. Okay? Gradient recalled echo, it captures what's called the T2 star effect signal. This best demonstrates hemosiderin. Okay? And some calcium products when you have a gradient recalled image sequence. Where do the hemosiderin spots arise from? Hemosiderin يجي if there is hypertensive microbleeds, cerebral amyloid angiopathy, familial cerebral cavernous malformation, axonal shear injury, multiple hemorrhagic metastases, all cause intracranial bleeding. After a long time, it becomes hemosiderin, and hemosiderin very well demonstrated on the gradient recalled echo as something called a blooming artifact. You can see here on this T2 there is nothing worth mentioning. When you do a gradient recalled sequence, you can see these dark spots. They are microbleeds. They are hemosiderin deposition, which can be easily not seen on the T2 weighted image. So gradient is also very important. In this case, the T2 has nothing here. When they do gradient recalled imaging, you can see these hypointense areas, the blooming areas, and when this is a 15-year-old girl, so when they did a CT, it was calcifications. Okay, so gradient is also important. Spectroscopy, it's a little bit complicated subject. However, we measure the concentration of metabolites in a specific part of the brain, like a tumor or abscess or whatever. Okay, these metabolites are choline, creatinine, NAA or N-aspartate and lactate lipids by a spectrum. Okay, and choline is marker for cell membrane or cellular turnover. It's a tumor marker. Creatine, it's evenly distributed, so we use it as a standard. We measure everything against creatine. NAA is marker of neuronal viability. Are the neurons live or dead? Lactate and lipid is for anaerobic metabolism, like abscess, for example. We have this spectrum. You can see the NAA is high. Okay, and this is the creatine, the standard, and the choline is also higher than the creatine but little bit less than NAA. Tamam? And while we see here, the NAA is much reduced increased, indicating there's cell death, while you see the choline, the creatine is fixed, the choline is higher, indicating what? Increased cell turnover. So it can help you to decide which kind of pathology is that. However, never ever report spectroscopy without having the full brain MRI. It's not a study by itself. It's complementary to the brain MRI. You don't report spectroscopy without, and there is a very nice lecture on spectroscopy on our YouTube channel. See it, it's like very important. Perfusion, it's a highly complicated imaging, MRI imaging sequence. It depends on the use of contrast, and see how much contrast reaches the brain in a specific amount of time, followed by post-processing by the computer producing these maps. For example, here is a cerebral blood volume demonstration. This is a mean transit time demonstration. It has a lot of uses and ways to interpret it, and it uses ecoplanar T2 star imaging, which is like very fast imaging, to see the contrast reach the brain at what time, how long, how much, how long does it take to drain from the brain, and things like that. Patterns of enhancement of the brain. Well, patterns of enhancement of the brain, they are very important. You have to know it. First of all, blood-brain barrier prevents contrast from leaking outside the circulatory system. When there is damage to the blood-brain barrier, contrast will leak, enhancement will happen. Parts of the brain that does not have blood-brain barrier and therefore normally enhance include choroid plexus, pituitary and pineal gland, tuber cinereum, and area postremia. These parts, they do not have blood-brain barrier. Contrast will leak from them. Periventricular enhancement is an intra-axial enhancement. What is the differential diagnosis? It includes CNS lymphoma, infectious ependymitis, primary glial tumor, and MS. Okay? For example, you can see here, this is the periventricular pattern of enhancement. Can be thin or thick. And you have the differential diagnosis. You can see the enhancement here, periventricular ependymal enhancement. Okay? Gyriform enhancement, it's intra-axial. Okay? Sorry. Gyriform enhancement, it's intra-axial, includes, causes the gyri of the brain will show enhancement. It will be seen in herpes encephalitis, meningitis, subacute infarct, and posterior reversible encephalopathy syndrome called PRESS syndrome. You can see this is the kind I'm talking about when I say gyriform enhancement. Okay? You can see like here, for example. Nodular subcortical enhancement, it's also intra-axial. When there is metastasis or abscesses or things like that, you can see multiple intra-axial masses or areas of enhancement. Ring enhancement, it's also intra-axial, can be seen in metastasis, abscess, glioma, infarct, contusion, demyelination, and radiation. There are different kinds of ring enhancement: thin ring enhancement, thick ring enhancement, interrupted ring enhancement, each C-shaped. Each one has its own differential. I will just not talk about that. You can see there are different kinds of enhancement. You can review them and see which enhancement means what. Okay? We have what's called pachymeningeal or dural enhancement. Since it's meningeal, it's extra-axial. Okay? It happens in intracranial hypotension, post-operative, post-lumbar puncture, meningeal neoplasm, and granulomatous diseases. For example, you can see here, this is the pachymeningeal enhancement. This patient has a VP shunt, ventricular peritoneal shunt, and it's over-shunting, resulting in intracranial hypotension. You can see all the meninges are smoothly enhanced. This is pachymeningeal enhancement. Okay? Leptomeningeal, which is the pia arachnoid enhancement, it happens in meningitis, leptomeningeal carcinomatosis, and viral encephalitis. It's on the surface of the brain. It looks like some kind of gyriform enhancement, something like that. It's similar to it, but it's not. You can see even the cerebral folia are enhancing by the pial folding. And that will be all. Thank you very much. I hope you had a good talk with that. Any questions?